Thank you so much for coming today for our amyloidosis talk, case challenges, success strategies for genetic testing. I'm Sarah. I'm with the France Foundation. I'm the staff moderator today. I'm pleased to announce our speaker and part of our steering committee and content creation, Dr. Kevin Alexander, assistant professor at Stanford University. Just some housekeeping notes. There are some Zoom polls that we'd love you to engage in if you're able to. If you're not able to get to a computer and respond to the polls, there are also QR codes. So we'd love for you to take out your phone and engage through our polling system that way. There is an evaluation at the end. We'd love your feedback on our education. It helps this education and all of our further education. And you can claim CME credit if you're interested in that as well. So with that, I'm going to go ahead and turn it over to you, Dr. Alexander.
Great. Yeah, thanks, Sarah. So over, I guess, the remainder of this hour, I'd like to talk about disease that many cardiologists will encounter at some point, and probably fairly frequently if you start to look for, and that's ATTR cardiac amyloidosis or ATTR-CM, and particularly highlighting the importance of genetic testing. So as Sarah mentioned, one of three on a steering committee that helped develop this content. And here are our disclosures. And so the objectives for this talk are to help to identify patients with heart failure who should be assessed for possible amyloidosis, describe the patients with ATTR-CM and how genetic testing might impact their disease management, and then ultimately outline the steps and available resources for genetic testing among patients with ATTR-CM. So first, we'll talk about what is hereditary ATTR-CM and give an overview of the clinical signs and symptoms. And then we'll give some illustrative case challenges about successful strategies for integrating genetic testing and how it might impact these individual cases in the vignettes that I show. And then we'll wrap up with some key takeaways. So there's a few pre-test questions. And so like Sarah said, if you are able to answer on Zoom, great. If you're don't have access to a computer, you can also look at the QR code in the top right here and answer on your phone. So there's three pre-test questions that I'll read out and then we'll readdress them at the end of the talk. So which of the following patients should be assessed for possible amyloidosis? A 75-year-old with HFpEF, left ventricular hypertrophy, low voltage ECG, and carpal tunnel syndrome. B, a 68-year-old woman with reduced ejection fraction, hypertension, and right hand carpal tunnel syndrome. C, a 70-year-old man with atrial fibrillation, coronary artery disease. Oh, let's see, let me go back here. Coronary artery disease and normal left ventricular wall thickness. Or D, a 72-year-old woman with a history of hypertension, concentric left ventricular hypertrophy, and no history of neuropathy or carpal tunnel syndrome. So I'll go to the next question. A 65-year-old person who was recently diagnosed with ATTR-CM asked during pre-genetic counseling, how will my genetic tests affect my medical care? In addition to saying it would determine whether the patient has hereditary ATTR-CM, which response most accurately describes the impact of genetic testing on disease management? A, genetic testing will benefit family members through cascade screening, while your treatment plan will follow standard guidelines for regardless of genetic results. B, genetic testing can inform your prognosis, potentially influence treatment selection, guide monitoring for mixed phenotypes, and enable testing for at-risk family members. C, genetic testing will help classify your condition for research registries and may benefit future patients, but has minimal impact on current treatment decisions. And finally, D, genetic testing can predict your response to ATTR-CM specific treatment and becomes relevant if you don't respond to initial therapy and can guide alternate treatment approaches. And then finally, which of the following is most appropriate regarding genetic counseling and testing for a patient diagnosed with ATTR-CM? A, recommend genetic counseling and testing if the patient has a known family history. B, recommend genetic counseling and testing if a patient expresses concern about family risk. C, recommend genetic counseling and testing discussion when treatment is initiated. And D, recommend genetic counseling and testing when a patient is diagnosed. So we'll come back to those questions after the presentation, and hopefully you'll find some information to help guide your answers to the questions that we just shared. So what do you need to know about hereditary ATTR-CM? So first, what is cardiac amyloidosis? It's a disease process where there's abnormal breakdown of precursor proteins that start to form insoluble rods of protein called amyloid, and they can deposit in the extracellular space of various organs, including the heart. The two most common types of cardiac amyloidosis are caused either by a protein called transthyretin, and that can lead to ATTR cardiomyopathy, or breakdown of a protein called light chain, immunoglobulin-free light chain, and that can lead to AL amyloidosis. So briefly, the pathophysiology for AL amyloidosis, immunoglobulin-free light chains are fragments of antibodies that are produced by plasma cells. When there's an abnormal clonal population of these plasma cells, sometimes they can produce a light chain that's prone to develop amyloid. And these amyloidogenic light chains can start to break apart and aggregate and form the rods of protein fibrils called amyloid. And they can deposit in a variety of tissues, including the heart, kidneys, liver, peripheral nervous system, gastrointestinal tract. It's a progressive disease that can lead to ongoing organ damage and dysfunction. And it's particularly important to diagnose this early, as there can be rapid damage, particularly to the heart, in patients with the cardiac manifestations of this disease. And that has a significant impact on prognosis. So, timely diagnosis and referral are key for managing this condition. In terms of ATTR amyloidosis, transthyretin is a protein that's produced in the liver as well as the retina and choroid plexus, and its job is to transport vitamin A and thyroid hormone throughout the body. When transthyretin is secreted from the liver, its native form is a tetramer, so four pieces of protein bound together. And what happens in ATTR is that these tetramers can begin to dissociate into monomers. And these monomers are thermodynamically unstable and have a propensity for misfolding into misfolded monomers that can start to aggregate. And these aggregates can ultimately form the protofibrils that go on to develop into amyloid and can deposit in the heart and other places. So among patients with ATTR-CM, there's two subtypes. There are individuals where a normal copy of the protein misfolds, and that's called wild type ATTR-CM. And that's usually seen as a disease among the elderly. And there's another subtype called hereditary or variant ATTR-CM. And this is due to a point mutation in the TTR protein that can lead to increased risk of misfolding. It's important to note that the penetrance of ATTR, hereditary ATTR-CM is incomplete, meaning that just because you have a mutation that can increase the risk of developing amyloid, it doesn't necessarily mean you'll go on to develop amyloid. There have been a number of ATTR variants that have been described, over 130 to date. Shown here are some of the most common ones seen in the United States. The V122I mutation is carried by 3 to 4% of Black individuals. And so this is something that you'll undoubtedly encounter in heart failure patients. About 50 to 80% of these patients are seen at amyloidosis referral centers. I think really just highlights the fact that there's probably an underdetection of this variant in areas outside of amyloid centers of excellence. The other two variants that are most commonly seen in the US are the T60A mutation, which is found among people of Irish descent, and the V30M mutation, which is found in a few different founder populations, Scandinavian, Portuguese, and Japanese. And so certainly you'll encounter these as well. We know that in terms of amyloidosis mortality, the burden is not equal across sex and racial demographics. This was a study looking at Centers for Disease Control death certificate information. And what you can see here is that Black individuals have a much higher reported amyloidosis mortality compared to other races, and men have a higher reported amyloidosis mortality compared to women. And so this starts to give you a sense of some of the groups that are more at risk for manifesting ATTR cardiac amyloidosis. We also know that there's geographic disparities in the reported amyloidosis mortality. One could hypothesize that given the higher burden of amyloidosis mortality among Black individuals, that regions of the country would have high proportion of Black individuals, such as the Southeast, would have higher reported amyloidosis mortalities. And what you see here is, in fact, the opposite, where areas in the Southeast had the lowest reported amyloidosis mortalities, highlighting the fact that there's also disparities in terms of the diagnosis rates across geographies. When we looked further in this study, there's additional signal that as you get farther away from established amyloidosis centers, and those are shown in the triangles on the right heat map, that the likelihood of diagnosing or rate of diagnosis of amyloidosis was lower. So I have the fact that if there's an awareness of this disease, you're more likely to think about it and diagnose patients. And so that's really the first step in terms of improving outcomes for this condition. As I mentioned, the prevalence of the V122I or V142I variant, just a difference in nomenclature, um, is carried by about 4% of Black individuals. And among Black individuals, women are particularly underdiagnosed with this condition. Shown here is a recent study that showed among TTR carriers that there's a high rate among carriers for cardiovascular disease, heart failure outcomes, and an increased risk of all-cause death. And so even though the penetrance of this variant is incomplete, you can see that there's a significant burden of poor cardiovascular outcomes among carriers of this variant. So for the first polling question, sorry, it just pops up on my screen here. So which of the following contributors to disparities in ATTR-CM diagnosis in treatment, sorry, it's just hard to see. In diagnosis and treatment of your patients are you likely to experience? And you can select all that applies. Misdiagnosis, lack of access to ATTR specialists, lack of access to emerging and novel therapies, and lack of diversity in clinical trials. So I'll give you all a second to answer that. And Sarah, I don't know if we'll be able to see the results. Oh, perfect. Yeah. So let's take a look here. So the numbers add up greater than hundreds. That means many people selected more than one. But the key themes here, it looks like there's kind of uniformity around misdiagnosis, lack of access to specialists, and lack of access to therapies are some of the big drivers of disparities for ATTR. Okay. So in whom to suspect ATTR-CM? So there's what we think of sometimes as red flag signs and symptoms that should raise suspicion for ATTR-CM and consideration of further testing. Certainly, if someone has a history of heart failure, atrial fibrillation, and certain bradyarrhythmias and conduction disease in the right population, that should raise suspicion. If someone has musculoskeletal manifestations such as carpal tunnel syndrome, particularly bilateral carpal tunnel syndrome, lumbar spinal stenosis, ruptured bicep tendon, and a history of multiple orthopedic surgeries, so shoulders, knees, hips, trigger fingers, those should raise some suspicion. Someone might have signs of polyneuropathy, so that could be sensory or motor neuropathy, or as well as autonomic dysfunction as well. And that can manifest as orthostasis, chronic GI symptoms, erectile dysfunction. And so patient might not necessarily have all of these manifestations, but once you start to see clusterings or combinations of these manifestations, it should raise suspicion or to at least think about ATTR-CM. And I think important to highlight that uh, regardless of the left ventricular ejection fraction, we often think of ATTR-CM as being a preserved ejection fraction with restrictive cardiomyopathy. Some patients may have a reduced ejection fraction, and so don't let the EF necessarily be the thing that helps you to stratify patients. In general, I would say I would have a lower threshold for screening for this condition because, as we'll touch on, there's a lot of non-invasive ways to confirm the diagnosis of this disease. So, in terms of the diagnostic algorithm, and this is a little bit of a busy slide, so let me kind of distill it down. So, if you have suspicion for ATTR-CM based on some of the things we saw on the previous slide, as well as maybe some imaging findings that are suspicious, then proceeding with the diagnostic screening is reasonable. There is a non-invasive way to diagnose this condition through scintigraphy scanning, but the scintigraphy scanning, while it's positive in ATTR-CM in most cases, occasionally can be positive in light chain amyloidosis, so that other type of cardiac amyloid I mentioned earlier. And in that case, a scintigraphy scan cannot differentiate between these two subtypes. And so it's important to screen for monoclonal gammopathy with serum-free light chains and serum and urine electrophoresis. If those tests are negative, then you can proceed with scintigraphy scan. And if it's an abnormal scan, you've confirmed the diagnosis of ATTR-CM. If there's a monoclonal gammopathy present, then a scintigraphy scan will not be sufficient to confirm the presence of amyloidosis and confirm the subtype of cardiac amyloidosis. And there you need to obtain a biopsy to confirm the diagnosis. You can do a biopsy targeting the organs potentially involved, so the heart or kidneys, for example. You can also consider a fat pad biopsy, although that has less sensitivity. And so in our practice, we favor targeting the organ that you think is clinically affected. And when someone is confirmed with ATTR-CM, it's important to pursue genetic testing to determine the subtype of ATTR-CM. So here's a case example. This is a 64-year-old gentleman with a history of heart failure, preserved ejection fraction, has a history of bilateral carpal tunnel syndrome back in 2018. In 2024, developed neuropathy and diarrhea. And this led to genetic testing, and he was ultimately found to have the V122I or PV142I mutation. And so you can see that there's a number of red flag signs and symptoms that have occurred over a 7-year period before this genetic testing. And so, ask rhetorically, where were the missed opportunities for diagnosing this patient, and how can you identify these patients earlier? And so, this is somewhat of a medical systems question because a lot of these patients will ultimately see multiple specialists and primary care physicians along their journey, not necessarily come directly to a cardiology office. And so, I think this is where figuring out how we can collaborate across disciplines and also to streamline referral pathways is going to be really important to get these patients to the right place and get the diagnosis made earlier. So the next polling question, what percentage of your HFpEF patients do you screen for ATTR-CM? Okay, so some uniformity there. So looks like everyone said 6 to 25%, which I think it's a pretty good number here. So we can talk a little bit about the demographics of and treatment options for ATTR-CM. So just to highlight the importance of diagnosing this condition, there's been a lot of drug development in this space over the last decade and is ongoing. And these treatments are clinically effective at improving cardiovascular outcomes in this disease. So to go back to the pathophysiology, as we showed before, this protein is predominantly produced by the liver and is secreted as a tetramer. And when these tetramers dissociate and become misfolded monomers, that's really the substrate for developing amyloid. And so below are some of the targets for ATTR-CM therapies. There's treatments that block the synthesis or reduce the synthesis of protein in the liver through a variety of mechanisms. So antisense oligonucleotides, siRNAs, and more recently, CRISPR-Cas9 gene editing. And if you have less protein being produced, then there's less that can go on to form amyloid. There's therapies that are small molecules that stabilize the tetramer and decrease the amount that can go on to dissociate and misfold into TTR monomers. And so there's a number of therapies there. And just to go back, in terms of therapies that are approved, FDA approved for ATTR-CM, there's an siRNA called vutrisiran that was approved for this indication earlier this year. For the stabilizers, there's tafamidis and acoramidis that are FDA approved. And then the third mechanism of action that's being studied in trials or therapies uh, to attempt to remove amyloid from the myocardium. And so these are monoclonal antibodies that bind to epitopes on the amyloid fibrils to promote their clearance. And there's a number of these that are in various stages of clinical trials. So some of the takeaways from the overview for ATTR-CM is that this is an underdiagnosed disease. There are extracardiac as well as cardiac signs and symptoms that should raise awareness of ATTR-CM. There's many variants that have been described, but there's several that are particularly important in the US, such as the V122I variant, which increases the risk of poor cardiovascular outcomes among Black individuals. There are disparities in both diagnosis and healthcare delivery that exist and require further investigation. And promisingly, there's a number of specific ATTR-CM therapies that are now FDA approved and available. So we would propose that screening all patients with HFpEF and some constellation of red flag symptoms of ATTR-CM, regardless of race, ethnicity, and sex, performing genetic testing on all confirmed ATTR-CM cases, and then finally identifying genetic testing and counseling resources in your practice environment to help co-manage these patients. So the next part of the talk, we're going to talk about some success strategies for doing genetic testing or integrating genetic testing into the management of ATTR-CM patients. So this first case is an 82-year-old African-American woman who presented with heart failure. She has this history of ischemic cardiomyopathy, kidney disease, and aortic stenosis. Her echocardiogram showed concentric left ventricular hypertrophy with preserved ejection fraction, as well as aortic stenosis. She underwent a scintigraphy scan that showed grade 3 uptake and a heart to contralateral ratio of 1.5. So this is consistent with abnormal myocardial uptake. She had laboratory work shown here, which showed a normal serum kappa lambda ratio, an NT-proBNP of 2400, and a mildly elevated high sensitivity troponin. Looking at the family history here, you can see the patient highlighted in the red-green circle in the middle of the page. You can look at the family history pedigree of her parents and grandparents. And you can see has 3 adult children. So in terms of next step, is genetic testing necessary for the patient? And in whom would you consider genetic testing for in terms of cascade testing? So the next polling question, testing for ATTR-CM, A, differentiates between light chain and transthyretin amyloidosis. B, differentiates between wild type and hereditary ATTR amyloidosis. C is unnecessary if the patient has a positive PYP scan. And D is unnecessary if the patient has a positive cardiac biopsy. Okay. So everyone said differentiates between wild type and hereditary ATTR amyloidosis. And so that's correct. As we saw in the diagnostic algorithm, this is what's needed to determine the subtype of ATTR-CM. And so in order to distinguish between hereditary and wild type ATTR-CM, you need to have a genetic test. Sometimes it comes up on endomyocardial biopsy if there's a variant fragment of ATTR is if it's not detected, does that mean there's wild type? Not necessarily, because the biopsy is not 100% sensitive for determining amyloid subtype. Certainly, if you see a variant fragment on an endomyocardial biopsy, that's consistent with variant ATTR-CM, but that's often not the case. That many of these patients we won't get that fragment with the mutation in it, and so you need a biopsy to ultimately confirm the subtype or sorry, the genetic test to ultimately confirm the subtype. So, as we're talking about, the PYP scan by itself is not able to differentiate wild type from hereditary ATTR. The mass spec on biopsy can sometimes miss pathogenic variants. And so there's been a number of case series that have demonstrated this. So what is the role of a genetic counselor in all of this? It's, first and foremost to provide education for the patient as well as providers, counseling for the patient family members, empowering both stakeholders with information to help guide further treatment and management. This is personalized based on the individual's family pedigree. And for cascade testing, it helps patients to understand the genetic risk and implications of doing the test, but also interpreting the genetic test results. So our next polling question, when do you typically refer patients with ATTR-CM for genetic counseling? Before ordering genetic testing, after receiving positive genetic results, don't typically refer to genetic counseling, or D, don't see patients with ATTR-CM? So everyone answered before doing genetic testing, which I think in general is very reasonable. And we'll talk a little bit about this on the next slides. So there are different models for pursuing genetic testing, not only for ATTR-CM, but other cardiomyopathies. Doing the counseling before genetic testing allows for assessment for past medical history and allows for selection of the right genetic testing. So are you just going to test for the TTR gene or a broader cardiomyopathy panel? Helps to give consent for patients and frame the discussion and make sure that patients are aware of all the implications of potential results before ordering the test. You can get authorization from insurance, make sure that the test is covered. And it's ideal for at-risk relatives who may be asymptomatic. And so there's no rush in terms of confirming whether or not they have the mutation. And so you want them to make sure they understand all the implications of testing and have some sense of what they would do with the results. The counseling can also be performed after genetic testing. And so here you'd have a much more targeted discussion around the implications of the testing results, how to go about cascade testing, who's at risk, and this would be first degree family members of that person who screened positive. And then connecting back to the cardiologist and other physicians who are caring for the patient to help understand what the implications of these test results are and ultimately also provide resources that the patient can refer to for more information about hereditary ATTR-CM. The genetic counseling, I think, in my practice, has definitely been helpful for facilitating cascade testing. So you find this in your patient. Oftentimes, the first degree family members are not your patient. And so it takes a little bit more legwork to identify these individuals, provide the counseling, and decide whether or not to pursue genetic testing. And so genetic counselors can really help to facilitate that cascade testing for a broad range of first degree relatives who may not live in your area, may not be in your practice. I would say that genetic testing, particularly for ATTR-CM, should not be performed in minors because this is an adult onset disease with many patients developing disease after the age of 50. And so getting this information would not immediately affect clinical management. It really should be reserved for the individual patient to decide whether or not to pursue testing and when they're adults. Just to highlight that genetic information cannot be used to discriminate by health insurers or employers. This is something that genetic counselors will discuss in detail and something important to remind patients of as well. So going back to that case that we discussed earlier, so she underwent genetic testing and is found to be heterozygous for the V142I variant. So in terms of this genetic testing results, how would you explain the result to the patient? Which family members should be referred for testing? And how does this result impact treatment decisions? And maybe here I would just open it up for people to um, kind of give their thoughts about how they would approach discussing this with a patient. So anyone have any thoughts about kind of how you would, if this patient were in your clinic, how you would approach kind of next steps?
You're muted. You're muted. Genetic.
Sorry, what was that? It's a little hard for me here.
So we would just say that the test was positive and that and how this can affect people in your bloodline, and I would definitely refer their family members for genetic testing.
Yeah, yeah. So I think that immediately for the patient, it won't affect their treatment options for ATTR-CM because there's a number of things available that I showed on previous slide for both wild type and variant. But like you said, it has implications for first degree relatives, so siblings, as well as children. And I think for adult siblings and children, considering genetic testing is reasonable. And I think that going through a genetic counselor can help facilitate that process. Okay. Um, so just to follow up on this patient, they're started on ATTR specific therapy, and the family underwent genetic testing as you guys recommended. So to summarize, the impact of genetic testing on management confirms whether or not someone has hereditary versus wild type ATTR-CM. It informs about prognosis and disease course. Patients with hereditary ATTR-CM tend to have a more aggressive disease course than wild type patients. And so this can give important prognostic information. It allows for identifying individuals that are at risk for developing ATTR-CM and providing the option for cascade testing. And you can also provide more supportive care resources around genetic counseling for these patients. Occasionally, it can inform treatment decision to say someone has concomitant hereditary ATTR neuropathy, and there's some additional treatment options that are available for that subset of ATTR. So the next case is a 50-year-old African American who presented with shortness of breath, was found to have HFpEF and LVH, a mildly reduced EF, and a restrictive filling pattern on echo. It started to develop some neurologic symptoms at age 52, and then subsequently developed some GI-related symptoms and unintentional weight loss at age 54. So over the course of 4 years, has evidence of restrictive cardiomyopathy as well as some neuropathy manifestations. So what's the next diagnostic step for this patient? And what do people think?
You have the echo results showing restrictive pattern. Ataxia.
A cardiac amyloid isn't
Yeah.
the PYR scan.
Yeah, the scintigraphy scan.
Yeah, so you'd want to do some confirmatory testing to see if there is cardiac amyloidosis. So there's a number of red flags here, but not necessarily confirmatory of the diagnosis. And so you'd want to ensure adequate diagnostic testing. So this patient underwent a genetic testing which showed the TTR mutation, but the cardiac biopsy was negative for amyloidosis, but did show some interesting myocardial abnormalities and revealed this myocardial genetic disorder. And so I think this kind of highlights the fact that the V122I variant is carried by 4% of Black individuals. And so it's not a rare variant. And so you might encounter cases where the genetic testing is abnormal, but there's another cardiac condition that explains their manifestations. And so particularly in this case, with the ataxia, that's a neurologic finding we don't typically see with ATTR, and kind of maybe raises a question of there being a different systemic disease causing the patient's symptoms. And so really correlating the genetic testing results with other diagnoses and signs and symptoms is important. Patients can be genotype positive but phenotype negative due to the reduced penetrance. depending on the age of onset of that patient. And so always important to make sure that even in a gene positive patient, that you're thinking about other diagnoses. And to go back to the point of genetic testing in children, I'd say in my practice the last few years, as these cardiomyopathy panels are being used more widely, occasionally I'll have an 18-year-old or a 20-year-old that's referred to me with V122I variant, and their cardiac condition is related to something else. They have an arrhythmogenic or non-ischemic cardiomyopathy unrelated to that mutation. And so I think it's something that as genetic testing is more widely used, we will find these variants, and we'll also kind of be tasked with making sure that there's not other cardiac conditions that could explain someone's symptoms. So the third case is a 49-year-old with a history of variant ATTR with both neuropathy and shortness of breath, has a history of type 2 diabetes, and is a carrier of this rare variant, the leucine 78 histone mutation. There is a normal ejection fraction on echo, moderate concentric LVH, and by atrial enlargement. And so in this patient, we have a confirmed ATTR, variant ATTR. What would be some of the next steps that you would think about for this individual?
You already have it diagnosed.
But he inherited it, right? You don't know if he actually
Further
manifested
testing of the kids again.
So moderate concentric hypertrophy.
it. You just assume. Wait, the IVLC is already big, right? He has a big septum.
Yeah, so so family history has symptoms of ATTR and has an echo concerning for ATTR.
So you need that. Or you diagnose it with basically one. We're talking about this. You basically have the septum dilation, right?
Biopsy is
Greater than 1.2 centimeters.
You don't need to buy it.
And you have.
Just get a cardiac MRI, right?
That's that.
Slide.
Okay. All right.
Right,
So yeah. Got it. Okay. So hearing a number of things. So let's go through this a little bit.
Yeah, QIP.
So, yeah. So I think you're all touching on it that we still have to confirm the diagnosis. This person, you'd have quite a high suspicion of having ATTR cardiac amyloidosis because of the family history and because of the hypertrophy on echo, et cetera. So this person got a PYP scan that did not show significant uptake consistent with cardiac amyloidosis. And so here's a scenario where kind of all the pretest probability is quite high for ATTR cardiac amyloidosis, yet the scintigraphy scan is negative for ATTR cardiomyopathy. So this is so what do people think in terms of why we have this discrepancy between genetic testing and imaging? And are there additional kind of diagnostic tests you would think about?
There's that incomplete penetrance in the gene.
So it could be incomplete penetrance, so meaning that the left ventricular hypertrophy that we saw in echo is related to another condition. So that's one possibility. Any other possibilities?
He inherited the gene, but he doesn't have to manifest it, right?
That's what incomplete penetrance is.
So is that just incomplete penetrance? Well, incomplete penetrance. Okay, fine.
Maybe it's just not impacting the heart.
That's what
Yeah.
I'm kind of getting at.
Yeah. So it could have the mutation and say it's causing the neuropathy, but it's unrelated to cardiac manifestations. Okay. I agree with that. And then the other one I'll add is that, these tests, the scintigraphy, which we, think of as a very accurate test, still does have a false negative rate, like any test, false positives and false negatives. And so what the takeaway here is that if you have someone with high index of suspicion, but negative scintigraphy scan, you should think about just pursuing the gold standard, which would be heart biopsy in this case. And this patient had an abnormal Congo red staining and then had the mass spec confirming the ATTR diagnosis. And so we found that over the number of case series have now described that certain TTR mutations can have a negative scintigraphy scan. The rare variant I showed you there, but there's been a number of other ones where there's been reports of false negative PYP scans. I think keeping in mind that the studies that validated PYP scans or scintigraphy scans for ATTR-CM looked at patients who had wild type or some of these more common TTR variants confirmed by biopsy, and then looking at PYP scans in those patients and confirming the accuracy. So the scintigraphy scans were basically studied against the gold standard of heart biopsy. So what that means is that cases that have more subtle phenotypes of maybe earlier disease or patients with some of these rare mutations that weren't studied in these original observational studies, we have less data for the performance of scintigraphy scans in those individuals. So I think for early stage patients, as well as those that have some of these more common TTR variants, keeping a high clinical index of suspicion is important if they kind of have a lot of these different red flag symptoms, and not being afraid to just do a heart biopsy to get a definitive diagnosis either way. If the heart biopsy is negative, you can be um, reassured that that patient doesn't have clinically significant cardiac amyloidosis. Unlike something like sarcoid, where the biopsies can miss disease because it's a patchy disease, a cardiac amyloid is a diffuse disease, and so if you get adequate sample from a few places in the right ventricle, you should be confident that it'll detect the amyloid if it's there. So next polling question. So through cascade testing of relatives, this patient with ATTR-CM, asymptomatic relatives test positive for the variant. Which of the following tests would be recommended next for screening? Getting a prealbumin test, a cardiac biopsy, a cardiac CT, or an echocardiogram. So these are patients that are gene positive and they're asymptomatic. What would you recommend kind of as next steps for them?
So the question is,
Wait, I'll answer this one for 1 minute.
Okay. All right. So everyone said echocardiogram.
Yeah.
And I think that that's a reasonable answer. So how to manage these asymptomatic TTR carriers is an area under active investigation. Doing kind of initial assessment of these patients to see what variant they have and what that variant is associated with. Is that variant described to lead to cardiomyopathy, neuropathy, or mixed phenotype? What's the typical age the patients manifest symptoms, and what's the penetrance? And so those things can kind of help risk stratify your individual patient. Are they within that age range where you expect to start to see symptoms? If it's a more neuropathy variant, you're going to focus your exam and review systems on more neuropathy manifestations. If it's a variant more associated with cardiomyopathy, you'll think about more kind of cardiomyopathy and heart failure related questions and interrogations. And in terms of initial cardiac screening, ECG, echo, cardiac biomarkers are always a great place to start. If you see any structural abnormalities on any of these tests, that would prompt further cardiac testing considerations like scintigraphy scan. Having a low threshold to refer to neurology so they can think about things like EMG and nerve conduction studies, very reasonable as well. And then let's say all those tests are negative or normal, then these patients should be followed longitudinally because they could develop cardiomyopathy and or neuropathy down the road. And the interval by which you follow up patients, there's no hard and fast guidelines, but typically what I would say is as a patient approaches the age where you start to expect them to develop symptoms, you're going to want to watch them more closely. So if a variant is associated with cardiomyopathy, say patients in their 50s and 60s, as they approach their, mid 40s, late 40s, you probably want to screen a little bit more frequently. If they're 20 years old, probably could just do the initial testing and say, okay, that looks good. We'll see you in 5 years or see you in 10 years. So it really just kind of depends on the age of that patient and when we potentially expect them to present with signs and symptoms of amyloid. So yeah, thanks for your engagement and for listening to this presentation. I'd like to highlight some resources for patients. This is an area where there's a lot of resources and educational material for patients through Amyloidosis Foundation, Amyloidosis Research Consortium, and amyloidosis support groups, among others. There's a number of entities that can help with genetic counseling, and there's a number of pharmaceutical company sponsored programs for genetic testing to for patients to access testing with reduced or no cost. So some of the key takeaways: genetic testing is recommended for all confirmed cases of ATTR-CM. Genetic counseling helps to improve patient experience and outcomes, and cascade testing can help identify at-risk individuals who may benefit from early intervention. And so with that, you go back to the pre-test questions and give you guys a couple of minutes to answer these. So I won't read through them, but you can take a look at this question, then I'll move on to the next. Okay, question 2.
Question 2, please scroll down. About B for this, right?
You choose A for the first question.
Yes.
Okay, and then finally the third question. Okay. All right, thanks. And if you want to claim CME credit, you can use the QR code at the bottom right here.
Thank you.
Thank you.
Yep. Okay, so I think we have a couple minutes. Any questions or comments that you guys have on anything?
What role does the cardiac MRI play in this, if any?
Yeah, so I think that it's a complementary test. And what I mean by that is if you have somebody that you suspect cardiac amyloid, but there could be other cardiomyopathies that or on your differential, say sarcoid or hypertrophic cardiomyopathy, cardiac MRI is a great test because it can help you point you in the direction of subsequent tests to order. So, cardiac MRI will show signs of consistent with amyloid, can give you more information about HCM, it give you more information about sarcoid or other non-ischemic cardiomyopathies. So I think cardiac MRI has a helpful role there. The signs that it sees for amyloid on the MRI, so things like increased extracellular volume or diffuse late gadolinium enhancement aren't 100% specific for cardiac amyloid. And so if you have suspected amyloid MR, you'll still need to do a confirmatory test, scintigraphy or biopsy. So if your index of suspicion is very high for ATTR, I would just do a scintigraphy scan or biopsy. If it's, well, amyloid's on the differential, but there's these other things that could be as well. I think MR has a helpful role in that scenario. So I definitely use MR, but for many patients, I go straight to, scintigraphy.
Thank you.
So going through like the pathway, so you have a high index of suspicion, and then you get like the PYP scan. Does the PYP scan differentiate between other infiltrated diseases versus cardiac amyloid, or is it just like, so let's say it's like a sarcoid type of picture, can it differentiate between those two? So
Yeah, it cannot. It does not, I should say. So this really is a specific test for confirming ATTR. And so if you rule out ATTR with this scintigraphy scan, all the other stuff kind of on that differential like sarcoid, you need other testing to evaluate.
So it is specific to ATTR.
Okay. Thank you.
Thank you.
Yeah, of course. Cool. Any other thoughts or questions y'all have?
Appreciate your time.
Thank you, sir.
Yeah, likewise. All right. Enjoy the rest of your day.
You as
See
well.
ya.